call the meeting to order. We do have several bills. I will tell anyone who's of concern or consideration, we do have a sign-up sheet. I know several have signed up for different bills, that the three that we're looking at today as well. We do not, at this time, the chair does not intend to entertain a motion for a vote on any of these, so we will most likely do these as hearing only. They do have often far-reaching considerations, and so we want to make sure we've well vetted those as we prepare the committee to vote on them and move good policies forward. I'm going to start with Chairman Senator Ben Watson to look at Senate Bill 303. If you could come up and get us started with that. Yes, come on up. Either, which one? You want him at the main? Yes.
Thank you, Mr. Chairman. Appreciate you hearing this bill. This is Senate Bill 303. Let me just say this is a piece of the puzzle when it comes to health care. And I know you are working on this in the House, and we've been working hopefully hand in hand relating to surprise billing. This is the Transparency or the Right to Shop Act. We're working on, I know with Representative Knight and Senator Burke are working on PBM legislation. There has been some network adequacy bills. And then the all payer claims database, which is going to be done, is actually in the Senate HHS tomorrow. So I'm looking forward to continuing to work with the House. Last year we did 1115 waivers and 1332 ACA. Real proud of that, and so I did ask someone recently. I said, we did Medicaid waivers and ACA waivers last year. This year we're also doing COVID-19 or coronavirus. I'm just wondering what we're going to be doing next year. So we'll see. This bill, Senate Bill 303, is pretty straightforward. The section 1 is with the definitions, but the meat of the bill is lines 46 and 47. Each insurer shall make available on its publicly accessible website an interactive mechanism and a toll-free number whereby any member of the public may, and it lists that. Basically, the insurance companies are required to post prices, and we've also included quality, because as we know, quality drives price. The higher the quality, the better the price is. And that's what we want for our patients. We want something that we improve upon quality, we drive quality, and the price should follow. And that's in line 55, 55, which is the HCC methodology, which is a CMS metric. And to be honest with you, there was a little bit of discussion in the Senate, and that was a little controversial because this is used with CMS and Medicare and Medicaid, but it's not necessarily used that much in the private arena. So all I really care about is driving quality. Now, the Commissioner of Insurance is also in this, in that he does the rules and the regulations, and that was on line 65, and line 71 has to do with the all-payer health claims database, which I alluded to earlier, and that's line 71. So if that passes, that may be maintained by the department. That's it. That's the big picture. I'm happy to answer any questions. It is, it's a straightforward bill, and it is looking for transparency and allowing someone to seek out and look for the prices, look for the quality, which is what we would like to do, continue to do in healthcare, and this is a piece of the puzzle relating to that.
All right. Thank you for the initial presentation of this bill. I know, I do hear that quality, I know, can save money, but there are times when increased quality actually costs more.
Well,
But when you're talking about healthcare, I know bad quality costs a lot too.
It can.
Sometimes far more.
Yes.
So. Who in the committee has a question or clarification? Chairman Knight.
Thank you, Mr. Chairman. Chairman, I think this relates back, and I had an opportunity to watch. I think in the Senate, y'all had some hearings over the interim or right before we came back, and if I'm not mistaken, part of one of those was, I think, dealing with this as you were starting to look at hospitals and our doctors and procedures across the state, and it was very eye-opening. Some of the data that was being presented that showed that you know, you may have an expert here at whatever location or physician or hospital, but the costs were much different than perhaps the results, and people have different specialties. But it was very eye-opening as far as transparency and letting folks know what was out there, the cost, and the results. So I want to thank you for, again, looking at this from a measure of transparency and giving the consumer a little bit more information to make their choices with.
Thank you, Mr. Chairman.
Representative Pirkle.
Thank you, Mr. Chairman. And thank you for the bill. When I go to get my car looked at, I talk to the mechanic and I say, about what this is going to cost me. And he can't give me to the penny, but he could come pretty doggone close. And I thank you for providing transparency when I try to find my health care choices. And here's one thing I don't understand, and you could help me out. And the HCCM, and I understand we want to look at readmission rates and volume, and you know how many times you've done this procedure, this utilization volume, and if you would help me understand, it's going to be a score of.
No, it's pretty well established. I'll give you the example that it really started with, and Dr. Newton may be able to help me out with this, in that if you remember back maybe 15, 20 years ago, CMS began judging hospitals and physicians on coronary artery bypass grafts, CABGs. So hospitals, centers, and physicians that did them more frequently had better outcomes, less complications, and their utilization was low. And as a matter of fact, several hospitals represented in this room worked deals out to get them in the sort of inside track that they did a high quality, high volume procedure, and they could do it at a reduced price and a packaged or bundled price. So I hope that answered your question. That's sort of a big picture question from that perspective.
Could I have one follow-up,
Sure.
Mr. Chairman? And so let's just assume that I don't know anything about these metrics. As a consumer, would it be fairly apparent? I'm paying for the stitches that go in my hand, and I happen not to be a hand model, and so.
Well, I would hope so. It will be left up to the Commissioner of Insurance to write the rules and regulations, and like in line 65 through 70. I mean, that's where hopefully he should be able to put it in line.
There's where the transparency to the consumer is going to come from.
Right.
All right. Thank you.
Okay.
I will say in healthcare, we're really still, I'd argue, maybe in the infancy of adequately measuring quality. We're doing more than we used to. We've measured it a while now. Hospitals are being judged on it, and frankly, payments withheld. So there's certain quality metrics, but there's a lot that is difficult to measure, and so these, by allowing the commissioner to promulgate rules and regulations, you'll allow it as the science of it and art even.
That's correct.
Advances.
And I'll give you an example. Another example will be accountable care organizations, which has been a pilot program through CMS, And that is one of those situations where it actually has been shown to drive down the cost of health care when it comes to Medicare. So basically over age 65 or the age blind and disabled, population Medicaid. But from a Medicare perspective, that has been saving millions of dollars, because if you do the quality metrics, example, diabetes, you're doing your eye exams, you're getting your feet checked, you're doing the A1C, you're driving the A1C down to appropriate levels. You're not in the hospital as much, your diabetes is not out of control. So when you use those measures, which is what quality is, with the recognition that obviously some people don't want to do that and they don't want to take care of themselves. So there are always the outliers. But if you drive those numbers down, you'll cost Medicare and us taxpayers less money. And so the quality is there, the cost is there, and that's the right thing to do when it comes by the patient.
Quick question on line 46 and 47, the public accessible website, interactive mechanism, and a toll-free number. And any member of the public, that's on purpose. That doesn't mean not just the people insured with that.
That's
You
correct.
want people to be able to look at
Access, right.
So it is on purpose. This does seem like a lot of information for a phone call for somebody who's not even a customer.
Well, it is. Well, phone call or website. That's true. But the federal government is also requiring this. So we'll actually come in 1 month ahead of the federal government. By executive order, this is being ordered, and CMS is going through the question period, and will be implemented 1 month after what we've done. So it's not like it's not going to have to be done anyway.
All right, if there's no other committee questions, thank you, sir. We do have a couple of presentations, a couple of people signed up to speak to this. If
Certainly.
you can give us, then we'll get back to you.
Thank you.
Jesse Wethington, if you'll come on up and identify your organizations for us.
Thank you, Mr. Chairman, members of the committee. My name is Jesse Wethington. I'm the Executive Director of the Georgia Association of Health Plans, which is the commercial trade industry group for health benefit plans in the state of Georgia. We were able to offer some comments on Senate Bill 303 over on the other side of the process, and wish to do the same here today for the House Committee on Special Access. I had the privilege of serving on the Lieutenant Governor's Task Force on Healthcare Access and Cost, where this concept was presented to us last fall. And have enjoyed learning more about this issue. What we would caution the General Assembly as you move forward through this is look at and emulate some other examples in other states where your colleagues have instituted right to shop programs. In general, we would emphasize the need to start small, prove the concept, and work through it and expand it so that you avoid any potential unintended consequences in terms of impacts to healthcare cost. Around contracting, the chairman knows quite well how the contracting process goes between providers and insurers. There's a concern that exposing some of this information to the public may have the opposite effect of the intent of the legislation, which is to lower healthcare costs, because what that would do to the negotiation process. Additionally, as you were speaking with Chairman Watson, we do have a concern about the toll-free number in terms of the administrative burden that would place on any insurance carrier having to take questions from any member of the public about this large volume of information. Additionally, there are some other state examples we would point to you to emulate, Utah and Nebraska in particular. I won't get into the details of those. In general, we would ask that the scope of this be limited at the outset to a specified list of services. I can go into those. There's a list of 10 or 8. We have a couple of specific revisions that we'd like to offer to the bill, but at this time, if there's not going to be a vote, I'll just reserve comment and see if there are any questions.
Chairman Knight.
Thank you, Mr. Chairman. And my friend, quick question. Obviously, you're representing the health insurance companies. Is that correct?
Yes.
In any way, does this, and for some of the measures that you've mentioned or suggestions or concerns you've had, does this apply to any of the physician, surgical centers, or doctor's offices, or clinics, in other words, healthcare providers that your insurance companies own?
I believe it would cover any service that's under the scope of the bill right now. It could be defined into the program.
Okay. But again, from a concern from a health insurance versus also your health insurance companies having subsidiary companies that, have their own surgical centers, their own kidney dialysis centers, their own subsidiary companies that own and operate in the same field as other healthcare providers. Is that, are we getting to an issue where, is that the concern you're having?
That's not the concern. The issue between the nexus of insurance companies and pharmacies has been discussed in this committee at length. I'm not aware of examples of dialysis centers or any other kind of surgery centers that are owned by insurance carriers. With the exception, we do have an integrated HMO closed medical model that I believe is exempt from this bill.
Well, you may want to go back and check with your large insurance carriers. A number of them do have their own subsidiary companies that do and are operating in the healthcare field, and actually surgical centers, dialysis companies, hospice center, hospice and all that. So they, there are in this market. So I'd be happy to provide you any examples that, if you're not aware of those.
That'd be helpful. Our concern is not based on that. It's around the contracting process with those, the large body of providers.
All right, it appears there's no more questions at this time. Thank you, and
Thank you, Mr. Chairman.
also, all right, Alan Hayes for SB 303.
Thank you, Mr. Chairman. I'm Alan Hayes. I represent America's Health Insurance Plans, National Association of Health Insurers. I'd like to first say thank you, Chairman, for allowing me to speak with you on this bill, and to the Lieutenant Governor's office and Chairman Watson, who's listened to our concerns on this bill. We are generally supportive of the bill. Again, I don't want to go over everything Jesse did. We're going to be aligned on that. We just have those few changes. I would like to, again, say to those working on the bill so hard, thank you for sponsoring legislation and working on legislation that's aimed to lower the price of health care for Georgians. Again, just same as Jesse said, we'd like to see a change in the toll-free number. At least limit that to, as I was sitting there listening, you could limit that to our membership. And that would accomplish the same goal as eliminating that 1-800 number. I believe that's going to be obviously more of a burden than opening up a website we already have for members to the public. I would also concur that we should try to limit the scope at the beginning to certain practices. And with that, I'll also mention, because it came up, in the hierarchical condition category methodologies. I mentioned this in the Senate committee hearing. It's not something that commercial plans, which I generally represent, are used to using. It doesn't mean it couldn't work, but there may be a better quality metric that we're used to using, so we wouldn't have to reinvent the wheel. So I would ask Chairman Watson and those of you working on it to consider leaving that maybe up to the commissioner, some nationally recognized metric that maybe the commissioner can come up with that would be more appropriate for the commercial plans. Otherwise, thank you, sir, for doing this bill.
Let's see. Are there any questions from the committee this time? I've got a quick question, if you don't mind.
Yes, sir.
Are the insurers preparing for the federal rule that is?
Honestly, sir,
is there still hope that, from an insurer point of view, that the comment period will change it or delay it, or what's the current
honestly,
status?
I'll tell you. So I represent AHIP in Georgia, so I concentrate on what's happening in this building. The first time I heard that the federal government was working on this is right before this meeting when Chairman Watson told me. So I can't really comment on it. And I'll be happy to share with you if we've made comments. And, we do have calls and we talk about what's going on at the federal level. I don't remember this coming up, but if we've taken a position, I'll be happy to share that with you and serve with you also in Lieutenant Governor's office. But again, I'm not familiar with what's going on at the federal government.
Chairman Knight, you have a question?
Thank you, Mr. Chairman. And again, I want to thank you for being here, and sort of a follow-up to, I guess, the comment I made. Is there any potential conflict here, again, with the insurance carriers, sort of putting this out and making this available when they're, making this across the board, including their own, physician practices that they own through their subsidiary companies? Do you see a conflict of interest there, or perhaps we need to look at that just to make sure that there's no conflict of interest if the insurance company is going to be putting this out? This information?
If the question is, if there's a situation where an insurance company owns a provider like that, they would be covered by this bill. So we'd have to disclose all the same information. There's no distinction between the two. Okay. If you think it's a conflict that we would put our data and for our owned entities next to others, I think that this quality metric that you're all working on, the intent of the bill is to have them all kind of side by side, apples to apples. So there shouldn't be a conflict. I don't see a conflict with that.
And that's I just want to make sure. I mean, there were a lot of issues going around right now with conflict of interest.
Yes, sir.
I think we ought to think about that. Thank you.
Thank you for your testimony. At this time, as there are, we've heard some testimony on this. It sounds like we have some follow-up planned and some further discussions, and look forward to getting those as we move forward in the process. We do have a little time on this, since this is already passed the Senate, and the first Senate bill we've heard. At this time, I would like to see if Representative Todd Jones is prepared to go ahead. Are you? If you're ready, we'll go on and let you present your. It's a House Bill 542. We're working off of LC 338337S for anyone who's looking on or needs to look it up. Thank you for being here. Thank you for working on this. I know this is not an overnight project. And,
no, Mr. Chairman, it's not.
It was not. It probably wasn't a one-man project either.
It was not a one-minute project either.
Thank you for your work on it this past year and your whole team's work.
No, thank you. Mr. Chairman, can I proceed?
Please do.
Okay, thank you. For those of you in the audience, because this is hearing only, I'm not going to do the projector. If you're interested in following along, next to my laptop, there's probably about another 10 or 15 presentations, so please feel free to grab them if you'd like. This is House Bill 542, LC 338337S. First and foremost, to the committee, I want to say thank you. If you recall, you voted and approved the study committee that allowed us to really get a lot deeper into this. As Chairman Newton mentioned, this is definitely not a simple bill, nor is it something that came together in a minute, but rather over the past year. What I'd like to do is, first and foremost, just bring you through what it is that we see as the driver, the landscape, and then ultimately what the solution is. I think that's probably a better way to approach this, Chairman Newton, as opposed to going line by line, because quite frankly, line by line, I think it gets a little bit kludgy. So first and foremost, when I stood before you in March of last year, I actually thought I was a creative person, and unfortunately, I learned in this summer, our past summer, I was not. Floor and trade was something that came to me actually in this committee as we were discussing CON, and the nomenclature that I put together really was analogous to what I had done in cap and trade in Europe in the 2000s. And so I came up with the idea of floor and trade to be able to create a minimum level of indigent and charitable care. Lo and behold, I learned over the summer, and I think to our entire state's benefit, that several professors at Northwestern had started to study this actually back in 2015. So once I was able to get a hold of them up in Chicago, we started to have an amazing amount of dialogue in terms of the research that they had done, et cetera. So you'll see the very first page. Effectively, I want to give them academic credit. The last thing I want to do is theme as if I did not do that. So first and foremost, the first page is that. I'm happy to give you the full report if you'd like to read it from the Hamilton Project, which in fact was their work. On page 3, I wanted to give you an understanding in terms of what the market is here in Georgia on nonprofits. And again, we put this in quotes, but generally speaking, the nonprofits do about $100 billion. In charitable care, they do about $7 billion. So let's just call it, for the purposes of the conversation, 7%. On page 4, you start to see, especially on the bottom right of the black dark box, you start to see that with even over $100 billion in hospital revenue vis-a-vis the nonprofits, we are looking at nearly 25% of our hospitals being at risk. And there's some other statistics you see there on the bottom left. So there's no doubt that this is a pressing issue. We talk about it pretty frequently, not just in this committee, but I think as a body. Page 5, the problem really, and I want to give credit to the Kellogg professors, we really were able to, I think, synthesize the challenge much more than just the rural hospitals need money. I'm not suggesting they don't, and they need capital. But at the end of the day, when you really start to look at the root cause, and if you think of first principles going back to your business classes in college, you really do come up with 3 summaries, and that's this. 1, geographic mismatch. At the end of the day, you have certain areas that have, I'll say, a high amount of covered individuals, a high amount of income, a high amount of assets, and not that much indigent care, whereas you go to a different part of the state and it's just the opposite. You don't have that flush balance sheet, you don't have that hospital that has all the new equipment, but yet their indigent and charitable care is going up into the 40, 50, 60%, so we do have a geographic mismatch. The second one is disparity in eligibility. One of the things we learned in the study committee, and this is something that was news to me, so for those of you on the committee, I think it's a pretty important data point. I did not realize that each of the hospitals are able to make up what they define as charitable care. So that could be 150% of FPL, 200% of FPL. One hospital testified at 400% of FPL. And by the way, that's federal poverty line. By no means am I casting dispersions, but I just thought that was pretty interesting that we have a system that has, I'll just say, a relatively moving target. And again, that's not meant to be a negative. And then last but not least, on lack of accountability, this is something that I think we all know. At this point, we don't do any third-party auditing. And for those of you who own businesses or are in business, every year my auditor comes in, and we're a private company, and not for any other reason, but just want to make sure the money's where it's supposed to be and it's being used for what the purposes are. On page 6, the solution. This again is generalized, but there are 3 main parts to the solution. First and foremost, setting the threshold. For those of you who have the bill, and by the way, it's hot off the presses, the latest sub, you'll see that we're going up to 200% of federal poverty line. And that would be consistent across the board as opposed to, like I said, that moving target. The floor. I cannot comment how important it is, the setting of the floor. And the setting of the floor will be left to a committee, and we'll get to that in one moment. And then finally, the exchange. Keep in mind, I know that this is a profound change. 49 other states have never tried this. The country has never tried this. To our knowledge, including the Kellogg professors, no other country has ever tried this. So this is profound. So in the bill, you will see the first year is a test year. For lack of a better phrase, and I don't mean to be glib, it's monopoly money. But frankly, the hospitals need to get used to it. Patients need to get used to it. Doctors need to get used to it. And frankly, the state needs to get used to it. We have no SEC function inside of the state, meaning the Security and Exchange Commission. I don't mean the football conference. And at the end of the day, we need to make sure that we are ready to handle something like this. So the whole first year is a test, and then right after that, you'll see in the bill, there is a 3-month moratorium. Basically a time for us to do exactly what you do in business. Stop, pause, analyze, and determine what went right, what went wrong, and how it is that we can improve it. At the end of the day, no matter how much we vet this, there is bound to be something that slips through, and I'm willing to admit that, just intellectual curiosity and honesty. Nothing is ever perfect coming out of the hopper, first and foremost. That's why we have literally 15 months of, for lack of a better phrase, a pilot. After that, the next 2 years would be bilateral contracts. And since David's in the room, I'm going to pick on him a little bit. That's CHOA buying from Grady, just as one example, and that would be a bilateral contract. Whereas, for instance, if in the 3rd year we would move to an exchange, and we'll get to that in one moment, but if you think of an exchange, think of the commodities exchange that we have in Chicago. On page 7, the impact, I'll let you read that. I don't think I need to go through that, but ultimately, greater access, greater efficiencies, and we hope greater balancing from a community. On page 8, this is important, especially given the fact I have a floor leader in here. There are no conflicts to the current governor's initiatives. That means on 1332, that means on 1115, and for those of you who weren't watching us today, we passed several surprise billing bills today, and this does not conflict with those either. On page 9 is basically a break, and then we go into what the concept is. So ultimately, and I'm going to fly through these pretty quick because you can see through pictorial, but what we're trying to do is create a bilateral exchange, meaning a bilateral contract, so then that way Hospital A and Hospital B will at arm's length negotiate. And keep in mind, for the hospital systems, we will judge them at the parent level, not at the child level. So if a system owns 5 properties, we will roll them up to the parent level, and then they will negotiate at that point, not necessarily at the I'll say at the independent hospital level. On page 11, you start to see that basically what the key decisions are. We've already talked about those. Those are, again, who's eligible, 200% of FPL. Number 2, what the floor is. And then basically number 3, in terms of creating the oversight that we're going to need to ensure this maintains integrity. For those of you who've ever traded, even as something as simple as buying 1 share of IBM stock, the fact of the matter is that when you look at the United States market, even more so than those markets in Western Europe, in Asia, and all around the world, the fact is the reasons our markets are what they are is because of the rigor and the fact that people trust that these markets in fact hold value, notwithstanding the latest 7 days. In terms of page 12, I start to basically give you guys a broader thematic around expanding setting the threshold, defining the floor, and then creating the exchange. Like I said, 200% of FPL. In terms of the floor, this is key. I found out that on the net revenue or gross revenue side, hospitals charge different things, right? An appendix at one hospital could be $10,000, an appendix at another hospital could be $15,000, but lo and behold, through what I think was probably accident, the government has figured out a way to normalize these numbers through codes. So we will be setting this against the codes, not against gross revenue. This is important, everybody, because what happens, an appendicitis that gets, quote, cured or taken care of or surgery, may that be in South Georgia, Central Georgia, or North Georgia, at the end of the day, we want some normalization around that revenue. And then finally, in terms of creating the exchange, 2 key things. 1, the indigent care or the indigent trust fund will absolutely be in play here. We will use that as effectively our repository because we need the match, and I think Chairman England would take me out if I did not say that. And then finally, in terms of the exchange itself having the proper oversight. In terms of the financial model, I'm going to skip that just because it's so detailed, but know this, page 14, you'll see all of the references. This was not just something that we just pulled, but rather see the references. Page 15, please note, we did use proxy. We used revenue as proxy. We didn't have the DRG codes as one example. So please, if you're in here and you see that and your hospital doesn't have it accurate, we know that. Please see number 7 on page 14. Finally, going to 16, this starts giving you the examples in terms of, in this particular example, Hamilton, they never got above the floor, whereas Floyd was above the floor, and you start to see that one's in a surplus position, one's in a deficit position, and you start to see how the credits would in fact start to be traded. Same thing with page 17, you start to see exactly what would happen in number 2 scenario, and then finally the result of year 1 would actually be a balanced market, which is exactly what we want. 60 million sold and 60 million bought. Moving to page 19, you start to see how important it is that we get the indigent care fund and that trust fund so that we do get the match, and I think that's important. And then finally, on slide 20, you start to see if folks are above or below the floor, what that surplus means and what the negotiations could be. Again, I want to stress with Emory, that's as one example, we use certain proxies there. That is not the coded revenue. So if you're here from Emory, please, when you see that, I don't want you to have a coronary. And then finally, moving into page 21, this starts to basically emphasize the fact that we're going through the exchange. Let me pause for a moment. The exchange itself will be at first a periodic auction. What does that mean? Today, you can go in the Chicago Mercantile Exchange and literally buy away. You can buy pork bellies, you can buy orange juice, you can buy about any commodity that you want. Here, we don't expect the demand to be that fluid, meaning on a daily basis, hourly basis. So we'll do a periodic auction. We'll let the committee determine when the periods are. My hunch is we'll probably start with every 30 to 45 days and let the auctions occur, and then from there, we will start to expand. Now, I'm not going to speak for the committee because I'm not assigned to it, but if I was on it, I would tell you that we would eventually have to get into derivatives, because my expectation is two things. One, the hospital systems will start to consider M&A as a way to basically address this issue, which is a good thing because we have a flow of capital into the rural hospitals. And the second thing is they will need derivatives to basically protect themselves from a long and short position that would cause them to basically get out of balance, and they do not want to do that. The last thing I will mention is, you will notice we're doing this in 3-year blocks. We know that hospitals have to make sure that they can make decisions. I know 3 years is not a long-term capital decision, but we know 1 year is too short. If we do this in 3-year blocks, we give them the opportunity to be flexible enough to move the capital as they flow. Last but not least, on bill explanation, I think you've already gotten in terms of who was covered. Hopefully you've gotten from me in terms of the timing. And then in terms of the governance, in terms of the oversight board, and again, the key there, in my opinion, would be that board and its ability to set the floor appropriately. Let me be clear. If we set the floor too low, the credits come in as not as much value, and we don't have a balance in the market, and that's not going to help anyone. We set it too high, and we basically squeeze the market. So it's important, especially during that test year, in my opinion, I'm going to be recommending, if I'm given any type of opinion into that board, I'm going to be recommending that we reset the floor at mid-year. This would allow them to effectively see what happens when the floor is set once, and then when the floor is set twice, and what happens to them in terms of, in a sense, the equilibrium that they themselves are tracking within, may it be one hospital or may it be in a roll-up of the particular system. Chairman, that's it.
I do appreciate your presentation. Plus, I don't know how anybody. I hope everyone knows that there is a handout that we were able to follow, which did help. Certainly a challenging issue. Could you go back to a little bit to the beginning for me, if you don't mind? Well, if committee members have questions too, but the problem that we have now is a what you would call an improper distribution of charity care. Is that what we're trying to solve? Is that there's some hospitals that are doing more than, quote, their share of
Yeah,
care. And they all have a protected certificate of need around them to prevent any competition. So they all operate a little bit under quasi-government protection. Mm-hmm. So tell me how the problem you're trying to solve.
So if you look at page 5, everybody, if you don't mind, to Chairman Newton's point, it's the very first one, and to me, Chairman Newton, this is why I listed it first. I do believe it's the first of the three, in my opinion, the point that you're making. So for me, when you think of, and I'm not going to name any brands because I'm not looking to upset anybody, but when you think of a nonprofit in a, let's just say, a suburb of, I'll just say, means, that hospital typically has, let's just say, a significant balance sheet, new equipment, a ton of doctors, nurses, you name it, providers across the board. We go down, well, I don't know if that's symbolic of my comments. We go down to, say, a rural hospital. It does not have the accoutrements that I just mentioned. The challenge is, up in that suburban hospital, the demand for indigent care is, let's just say, in the single digits at most, whereas demand down in South Georgia, that demand is easily in the double digits, and what we're finding is sometimes as much as 40 to 50%. So in our mind, we have a geographic mismatch of the allocation of the nonprofit status that we provided in terms of that benefit is, and again, that benefit goes into the billions of dollars. So we feel as if this is a way, and again, I can't stress this enough, I was about to say Dr. Newton, Chairman Newton, is that it's important that that everyone understands this is no different than just setting a framework, and we're letting the players, meaning the hospitals, decide how the capital should flow, and not the government to decide how the capital should flow. Is that?
Okay, thank you.
You're welcome.
Representative Pirkle.
Thank you, Mr. Chairman. And
could you give us a quick summary yourself of this bill while you're?
I would love to. I would love to. Representative Jones and I have had many
Well,
conversations about this bill, and I was present with him when he presented it to a small-town mayor this past week, who was so giddy with excitement that he was just pounding the side of the chair because it was welcome news. You did a great job explaining it. I was not there. I have to check with Uncle Don. I was not there when Orville and Wilbur took off in North Carolina with the first plane. But this is an exciting day, I would think. This is to bring this to this committee. It is complex. But it does have real world applicability. We see an opportunity for us, I think, in changing the way healthcare is viewed in this great state. On page 12, I did have a question. That was a long way to get there, but you wanted me to do an overview.
You're there.
But on page 12, regarding the floor, and you look at the DRGs, and this is one of the areas that it took me to gain a grasp of, because we hear so much of the $15 aspirin that you see, and you can assign different prices for indigent care, and there really was no standard in the past how we define indigent care and in terms of the cost. Is it fair to say that using the DRG codes takes that out of the equation? So we're looking at, in economic terms, it would be a util. You could call it some quantitative code that then you can trade basically in these utils or units across all of the DRG codes, and someone would have to come up with that, of course, because it's not, you're not assigning a monetary value at this time, right? It's a util.
So if you're talking about what you're calling a util, the credit itself?
That's right. The
Yeah.
DRG code for the floor for the
Right.
credit, yes.
Yeah, so the DRG, that's the inpatient code is one example. And so we think of that as when we think of taking the revenue from all the hospitals, and again, let's just assume for a moment it's $100 billion just for easy math. And if we were to do and ascribe the codes to it, chances are it would not be $100 billion. It'd be something lower than that because the codes would bring that down. So then at that point, then look at the indigent care that they have provided. It's probably not $7 billion. It's probably something lower than that. We go ahead and we say, okay, let's just assume for the purposes of this discussion, Representative Pirkle, let's assume for a moment that's 5%. The oversight board may say, we're going to go ahead and set the floor at 5% or 5.1 or 5.2%, encouraging just a little bit extra in terms of what that indigent care could be. But absolutely, the normalization vis-a-vis the codes, the Medicaid, Medicare codes, is absolutely critical here, because if not, if we went by gross revenue, we would actually be encouraging, I'll just say, poor behavior.
Thank you.
And now, just one quick clarification. You've mentioned a couple of times suburban hospitals and rural hospitals, but there could be very high-need urban hospitals
Urban hospitals.
as well.
Yeah, and I apologize. That was
No,
just
I'm
strictly an
just-
oversight.
Clearly there are some challenged, extremely high indigent care, urban as well. So this is addressing that, no matter the zip code, as we say, an effort to try to make sure that the charity care burden, if you will, or opportunity is fair. Representative Houston. Chairman Houston.
How in this bill do you distinguish between not-for-profit hospitals and for-profit hospitals?
So this is only going to cover nonprofits.
Well, I was looking on page 22.
Oops, do we have a typo?
Oh, 22.
Oh, what I was referring to there was there are public nonprofits and private nonprofits, as opposed
What's
to,
a private nonprofit?
we have a few inside of the state of Georgia, Emory being one, for instance.
Okay, thank
Okay,
you.
You're welcome.
All right, we do have someone signed up to talk. Thank you for your presentation.
All right,
And
thank you.
I appreciate all the work you've put in here, in this bill. You've really worked hard on it. And thank you for bringing us something outside the box.
Thank you, Chairman Houston.
All right, thank you. Carrie Conley, if you will, go and just let everyone know who you're with and
Thank you, Mr. Chairman. I'm Carrie Conley with the Georgia Hospital Association. I'm their General Counsel and Senior Vice President for Healthcare Policy. Thank you for the opportunity to be here today, and thank you to Representative Jones for his extensive work on this issue. He's forced us all to think outside the box, which is a good thing. This committee, I know, is well aware, and it's been referenced multiple times already, that healthcare financing is complex, and that includes the financing for indigent and charity care. You all should have a copy of the presentation that GHA did to the House Study Committee on this trade and floor concept back in October. Because this was done back in October, it's not the most recent data that we have. I think we probably are capable at this point of giving you some 2018 numbers, but we'll have to get that updated for you. This is what the committee saw. And I won't going to take the time to go through the entire presentation, but I will note, just so that we're all using the same terminology, and because the presentation uses the term uncompensated care throughout, their uncompensated care and indigent and charity care are often used interchangeably, but indigent and charity care is actually one type of uncompensated care. Other types of uncompensated care include bad debt, which could be either that typically when you're expecting somebody to pay and they don't, whereas with indigent charity care, you're never expecting to receive payments on those services, or in situations where Medicare or Medicaid in particular do not cover the cost of the care provided by the hospital. So the bill that we're talking about today in HB 542 is just talking about that indigent and charity care piece of the uncompensated care. So as Georgia's efforts to decrease the number of uninsured patients that we have here in the state via the waivers, the 1115 and the 1332 waivers that were mentioned earlier, that will provide increased access to affordable health care coverage, those indigent and charity care numbers should go down. That's what we've seen in other states. As more patients become insured, those indigent and charity care numbers go down. What we haven't seen in other states is that those bad debt numbers don't go down. In fact, the bad debt numbers have continued to go up, even as the number of uninsured residents of those states go down. And that's usually due to the fact that you see with health insurance policies now, in order to make the premiums affordable, you have much higher deductibles and cost sharing that patients often can't afford to pay. Representative Jones talked a lot about the geographical mismatch, and if you look on slides 4, 5, and 6, you'll see maps of the state, and it helps to illustrate that point a little bit. You can see where the indigent charity care is being provided in the various counties across the state. What I don't think comes out in terms of the bill is that Georgia's current system for addressing indigent charity care does already take into account this mismatch. Georgia, for a long time, has been one of the few states, if not the only state, that actually requires healthcare facilities to provide a minimum level of indigent and charity care. So in other words, we already have the charity care floor that's talked about in the bill. And that is 3% of adjusted gross revenues for hospitals. It's 2% or 4% for ambulatory surgery centers, depending on whether or not the ASC sees Medicaid patients. And if a facility, regardless of the type of facility, doesn't meet that floor, then they have to pay the difference into the Indigent and Charity Care Trust Fund, the ICTF, and those funds are used to draw down federal Medicaid funds, and some of those federal Medicaid funds are then used to pay disproportionate share hospital payments, which are paid to the hospitals that do a disproportionate share of uncompensated care. The geographic mismatch is also taken into account in the hospital provider payment program, sometimes referred to as the hospital provider tax. In this program, hospitals pay in an amount to the state based on their net revenue, and then in receipt for that, they receive an 11.88% add-on payment to Medicaid claims. So for a hospital that does more Medicaid business or has a higher percentage of Medicaid patients, they're going to receive a larger proportion of that provider payment program payment back in terms of payment for Medicaid claims, to the point where hospitals that do a lot of Medicaid come out ahead, and the hospitals that don't have as many Medicaid patients in their communities actually come out in a loss at that program. And that's important because it's not, while Medicaid is not indigent charity care, the hospitals that do larger portions of Medicaid are also typically the hospitals that see a larger portion of uninsured patients. So these two programs already exist in Georgia, and they're already redistributing funds between the geographically mismatched hospitals. We fully believe that this bill is well-intentioned. There are a number of technical issues that we think would hinder its ability to operate the way it is intended. First and foremost, it's going to place a significant administrative burden on the Department of Community Health. DCH is going to have to be responsible for designing and operating, I think what we've all heard is a very complex exchange system, and there is no existing model for how to do this. DCH would have to calculate the various values of the charity care credits based on the Medicare DRGs, but my understanding is that the department doesn't actually have the ability to do this right now, and that's not a knock on the department. A number of hospitals don't have the ability to do this right now, and that's because it's typically Medicare that does that calculation. So if the department, or again, sometimes even hospitals, have to have those numbers, they have to contract with a vendor, an outside vendor, to do it for them. The hospitals, or the department would have to further refine these charity care valuations for each particular hospital. The way the bill reads, at least the version that I had, I understand there's a sub, indicates that each hospital has its own individual charity care floor calculation. So right now, when the department enforces the charity care floor that it has, it's 3% across the board, whereas moving forward under this bill, they'd have to calculate it for each individual hospital and then enforce that as well. Even if DCH has the capacity and the capability to administer the program, the design raises some compliance concerns under federal law. Excuse me, my device is acting up here. For the first year, hospitals would contract directly with each other before the exchange is up and running. And this potentially raises some federal anti-kickback issues. Every time that one healthcare provider pays money to another healthcare provider, you have to do an anti-kickback analysis to make sure that you're in compliance with that, again, rather complex federal code. Any buying and selling of credits, whether on the exchange or through the individual contracts, will have some kind of impact on both facilities' Medicare cost report. I can't tell you right now what that impact would be, but that's something that we need to figure out before we move forward with this proposal. It's not clear how DCH would be able to pay Medicaid payments from the Indigent Charity Trust Fund back to the seller of the credits. Right now, my understanding of how the exchange is intended to work is that the seller of the credits puts the credits in the exchange, the buyer hospital sends the payment to the Indigent Charity Care Trust Fund so that we can have that all-important Medicaid fund drawdown that Representative Jones talked about. And the issue is that I'm not sure then how we get the money, the Medicaid dollars, back to the seller hospital which is the intent of the legislation in order to deal with that mismatch. There's no claim to be paid, so we can't link it to the claims. It would have to be a form of supplemental payment, and we do make supplemental payments now. CMS has made it very clear over the last couple of years that they do not like supplemental payments. And there's also a federal cap on the amount of supplemental payments that we can provide to different types of providers. So again, we'd have to make sure that all of this is doable under the federal Medicaid requirements before we move forward. And then lastly, there's just some sort of logistical or operational concerns. At least in the version of the bill that I have, it contemplates that, or requires that before a facility can buy or sell credits on the exchange or under a contract directly with another facility, that the hospital has to have already met its floor. And so it's not clear to me what the incentive is for the hospitals to participate in any kind of exchange when they've already met their floor requirement. The bill, because we're doing a little bit of a pilot program and rolling into a full-on exchange model, the bill contemplates that hospitals will be subject to both the requirements in HB 542 and the existing charity care requirements under the Department of Community Health at the same time. And so we're not sure just logistically how that would work. As Representative Jones said, the idea is that the exchange will operate year-round, and that even if at the beginning you can't just buy and sell whenever you want, that there will be periodic times throughout the year that you can buy and sell credits. However, indigent charity care or uncompensated care is only calculated at the end of the year, because that's when you know how much you've done, and so a facility won't know whether it has credits to buy or whether it has credits to sell or whether it needs to buy credits until the end of the year when they've been able to go through their financial audit. Excuse me, my throat's getting all dry. And then lastly, the way that the definitions in the bill work now, I think Representative Jones said that the bill only applies to not-for-profit hospitals and not-for-profit ASCs as long as those ASCs are not owned or operated, are not owned or operated by a hospital. I'm not aware that there are actually any nonprofit ASCs in the state that aren't owned or operated with the hospital. And of course, that's important because the existing requirements apply to not just hospitals and ASCs, but all types of healthcare facilities, regardless of their nonprofit or for-profit status. And the initial purpose, or at least one of the initial purposes, into putting what is already a unique system into place in the state in terms of having that indigent charity care floor, is to help the hospitals that have to treat the patients that show up in their emergency rooms no matter what, to help spread some of that burden across other types of providers who don't have to treat all of the patients that show up at their facilities, and that portion is left out of this legislation. So with that, me and my dry mouth will be happy to answer any of your questions.
A couple of clarification questions for what things you mentioned. You did mention the current floor of 3% of adjusted gross revenue. Is that after contractual adjustments?
Yes, after
So the adjusted gross
adjusted gross
is.
revenue. I'll have to look up the definition of adjusted gross revenue.
But
It
when
is defined by the department.
But when the charity care is counted, say somebody who's under 100% or 200, I think do you agree that there's a fluid, uncertain amount on what's that it's not consistent, right? So if someone, let's just say under 100% that wasn't eligible for anyone, had a procedure, an operation, would the list price, the hospital charges, be the number that's used against that adjusted gross revenue?
So for purposes of, I guess first off, it's absolutely fluid from hospital to hospital. The
Everybody makes
state
their own
defines indigent care as anything below 125%. But charity care is done on a sliding scale, so it varies from facility to facility. It was referenced earlier that some facilities may go up to 400% of the federal poverty level. That doesn't mean that that person's getting free care, but it means that they're getting some sort of discount. It may be just
off the listed price.
Off the listed price, exactly. Okay. Or a number of hospitals now, as we have this issue with the bad debt and the higher deductibles, oftentimes now insured patients are eligible for the financial assistance policies, and that's just applied to their deductible or cost-sharing portion. So regardless of how the hospital defines their financial assistance policy, for purposes of reporting to the state, they do use charges, because that's what the state form asks for.
Even though nobody's really paying those, right? You're
Correct.
not getting those from Medicare, Medicaid, insurance even, right?
Right, but the numbers that you have in that packet, the numbers that the association calculates when we talk about this and when we put into our materials, those are based on cost. So you'll see the difference. Representative Jones, his presentation I think has $7 billion in indigent charity care. Ours is a much lower number. It's still high. It's over $2 billion in uncompensated care. But the difference there is the fact that we convert the number to costs instead of charges. And we can do that fairly easily because the Medicare cost report requires all hospitals, as part of the cost report process, to calculate a cost to charge ratio.
Is part of the concern, I'm trying to get it clear, do you think this is going to result in more money going to hospitals that do high indigent care, or less money, or this, I mean?
To be honest, Chairman Newton, I'm not
is.
even sure that I've gotten that far in my mind yet, because I'm still struggling a little bit with the implementation in terms of how are we going to get Medicaid money under this process, because there doesn't seem to me right now to be a way to actually draw down the federal dollars, and if we can't do that, then I don't know how it's going to help.
We do have just a few minutes before another committee meets, but Chairman Knight and then Chairman Houston, please.
Quick question, and again, I don't want to take much time because I know this, actually my committee's about to be.
Never mind, we'll
And
take all the
it
time
is
you
a
need.
budget. It is one of our higher ed budget times. And I'm going to ask you to get this to me offline. You'd mentioned formulas. So how many years since the formula was set? And again, you get this to me offline. So that's one question. And then are the reports from the hospital, which form the basis for payments, independently audited? Quick, I don't want to answer now. Just if you don't mind.
Okay. Medicare cost reports are audited, yes.
Okay, and Chairman Houston. Chairman Houston. Sorry.
One thing I couldn't really understand, you were saying that there wouldn't be an incentive once they met their floor. Would you explain that to me? There'd be no incentive to do indigent care?
No. There would be, the way that I read the bill right now, a hospital would be required to meet their charity care floor, whatever the percentage is, before they're eligible to participate in any kind of exchange.
Yes.
And so if they've already met their floor, which is what would be required of them, then there's not an incentive to do the exchange because they've already met their requirement. And I'm not sure if that's,
Well,
I'm not sure if that's
they
the
have
intent
gotten
or
to
not.
continue to take indigent people regardless of whether they met their floor or not.
No,
If you're a
absolutely.
nonprofit.
Right, absolutely. And so I think the question is, what would be the incentive for the hospitals that don't do as much indigent and charity care to buy any credits if, from a state enforcement standpoint, they've already met their requirement? The purpose of the exchange, the way I understand it, would be to help the hospitals that don't do as much indigent and charity care meet their requirement. And I think, and again, I don't know if that's the intent of the bill, but that's the way that I read it now.
All right, thank you. And thank you for your presentation. I think we will go on and conclude the meeting today. I apologize to those who came for House Bill 991. We are going to take up that important measure very soon. We do want to keep moving along. These were complex issues and require much thought and consideration. Thank you for your consideration. We're adjourned.